Medicine's greatest secret is our inner healing potential, and it's most powerful under anesthesia, when we let go of the reality we think we know. Hello, this is Dr. Anthony Cave, a Stanford and Harvard-trained anesthesiologist and integrative medicine specialist. And today, I'm going to share a powerful story from a patient who first came for surgery being labeled as a seeker. Do you know what a seeker is and what that is a code for in the medical system? And how they woke up with having fallen asleep with this terrible opioid addiction, waking up and saying, "Doctor, I'm walking away from him in recovery." I turn around. I'm like, "What's up?" "Doctor, thank them." I'm like, "Thank who? The surgeon? Want to thank me? The nurses? Who do you want to thank?" He's like, "No, doctor, thank the oxys." And this was the start of this patient not touching opioids again since last I connected with him. Because he woke up saying, "Thank the oxys, because they helped me in a rough time. And they hurt me for much longer. I let them into my life, and I'm letting them out the door." Patient told me this when they were waking up from anesthesia. Someone who'd been suffering for years with an opioid use disorder, to wake up after surgery. What happened to their brain before they came in for surgery under anesthesia? What kind of psychedelic experience did I foster in them to help prime their mind to have this awareness of the control that they've had from the beginning over their opioid use, and waking up with this deep insight, which kind of bone-chilling, makes the hairs in the back of my neck stand up. What happens to opioids when you're under anesthesia? How do we adjust the anesthesia? How do we help foster this experience? And what does psychedelics have to show us and teach us about addiction? And what is addiction? We're going to talk about that, but we have to start with what a seeker is, because that's what happened. I walk in, it's like a Tuesday morning. The first thing the nurse tells me is, "This patient's a seeker, doc." And I'm like, "Seeker? Seeking what?" Nurse is already gone. I love this nurse. He's solid, very caring for patients, but he's also admitting like 5 patients in an hour and doesn't have time to go into the deep part. I understand. But when someone's a seeker, usually, unfortunately, it's just short code, medical code for a drug seeker, someone who needs opioids or wants opioids, and we kind of dismiss them saying, "Oh, they're just here for Dilaudid, or they're just here for fentanyl, or they're just here for some sort of IV pain medication." Now, you first got to start with here. If you want to help support a cure in somebody who's coming to you with a severe addiction, it doesn't matter if it's alcohol or sex or gambling or opioids, it doesn't matter, because the first stage is, what are they seeking? Because the addiction is often a symptom of something that's unfulfilled in the patient. By the way, Chris, Iris, Michaela, Hannah, Paul, good to see everyone coming on. I'm quite excited to share, Michaela, just like you said, the story, because it's so demonstrative of what happens to the brain under anesthesia with the psychedelic experience, with the love and compassion and guidance that patients deserve. They deserve no less when they're putting the trust of their lives in our hands in the medical system. So a seeker, we need to get rid of this concept of, "Oh, they're a seeker," and just say that's unanimous or synonymous with a drug seeker for pain meds, because clearly they're seeking something else. I'm not going to go into the history of this particular individual, but suffice to say that they thanked the oxys because they were helping them at some brief moment in life to fill a gap that he was seeking to be filled, or seeking to have filled. So we're not seeking oxys. I mean, yeah, we are, right, superficially, but there's some emptiness or some hurt or some pain that is probably the root cause. First and foremost, how are we going to address, how am I going to help this patient undergo surgery where they're going to probably get opioids, unless we talk about this. And the last thing I want to do is give opioids to a patient who is struggling with opioid addiction. It's like giving alcohol to an alcoholic. not the way that we foster an environment to help prevent further opioid cravings. So this individual was seeking something much deeper than opioids, and labeling them as a seeker, not good enough to address the root cause, not good enough for a patient of mine who I want to help go through this process and heal the mind as much as the body. So this individual had tried Suboxone and methadone, and there was some relief with those. They certainly are FDA approved for a reason for opioid use disorder. And I'm not saying that they're bad or that they're ineffective, but I'm saying that if we want to address the underlying cause of addiction, giving opioid agonists that have different levels of activity, like methadone and Suboxone, or buprenorphine, I should say more specifically, isn't addressing the same root cause that this experience helped to this patient. So, what is an addiction? First is super simple. Short-term benefit, long-term harm without the ability to hit the abort button. If you know me by now, I try to keep things very simple and short. It's helpful. If I have a patient under anesthesia, they're not really going to be following me with Shakespeare. We're going to be working on something more bite-sized. So like we said, addiction is anything that provides us short-term gains or benefits, long-term harm, and an inability to hit the abort button. Hey, Sheila, good to see you. I gave you a shout out last time because you were the first person to, on the topic of opioids, recognize that intraoperative opioid dosing is about 1 million times less than the amounts that are dealt on the streets of San Francisco. So another shout out because I see you on here, Sheila. Awesome. Hey, Michelle, good to see you as well. I agree. This definition of addiction is very straightforward. And even if you're working with someone under anesthesia, to kind of remind them, what are we trying to work on here? It helps keep things super digestible, even if our mind is in a different state. So I'll ask you, I'll start with myself. I'll be vulnerable with y'all. This definition of addiction is not just for opioids, it's for anything. How about anxiety? Right? If there's one thing I want you all to take away, is just for yourself, recognize one addictive habit loop that you have. It doesn't have to be as extreme as heroin or alcohol or something. It could be something like mine. I, for the longest time, had this little anxiety addiction, like a adrenaline addiction almost, where if somebody would call for an airway emergency, my ears would perk up, my heart rate would speed up, and I would get anxious. I would feel important because it's like, oh, somebody needs a doctor. I'm here, guns blazing. Let's do this. Well, and what am I enforcing? So there's a TBR loop. I love Dr. Brewer's way of breaking down the concept of an addiction. There's a trigger, the T, a behavior, the B, and a reward, the R. So in my habit loop, and just I am only sharing so that you know that we're all in the same boat as humans. We got a shared humanity here. You probably have more of these than you know. I certainly do. And I'm sharing one example. Trigger for me, airway emergency, code blue, call anesthesia. Trigger. My behavior. Oh, self-importance welling up. I'm the one who needs to help somebody here. This level of arrogance to an extent, right? And what does this bring up? Like, oh man, the only person who can fix this problem here, like, pressure's on me. So you go almost from arrogance to this level of anxiety. Because it's like, what am I going to do? I got to do this fast. You start to lose control. Start to lose a little bit of control. Now, nothing bad ever happened, but it's not the healthiest way that I can respond. What's the reward from all this? Well, despite my anxiety, I still felt proud and puffy-chested. And I came here, I rescued the airway. I got the fiber optic scope in there despite all the blood gushing out into the oropharynx and quickly put that tube past the vocal cords and maintained ventilation. Yeah, right. So this reward, clearly a little dopamine rush of feeling self-important and, oh, I'm so special. Well, the same thing can happen not only when the good stuff happens, but for the bad stuff. And I'm so anxious, like I'm the only person who can do this. What if I fail? What if something goes wrong? Well, my behavior here in response to trigger is like, oh, well, I'm so special. I have needs that are greater than anyone else in the hospital. Oh, I have concerns that are more important than anyone else in the hospital. You can see how this is still self-importance, but on the other side of the spectrum, where my worries, anxieties, etc., are so much more important than others. The reward is the same thing. I'm feeling self-important, little dopamine rush. So this is a personal example of a habit loop that can lead to an anxiety addiction. In the case of opioids, classic. You see the fentanyl on the street or even in the operating room, which is what happens to many healthcare providers that develop an opioid addiction. That's the trigger. The behavior, shooting oneself up, and the reward is clearly going to be an intravenous bolus, immediately crosses the blood-brain barrier and hits your brain, of having one of the most powerful euphoric effects known to mankind. Now, I ask you, especially as we have a new year ahead of us, just think of one habit loop that you have and try to go through this thought exercise with yourself. Now, you'll wonder, well, what is the point of psychedelics and if we can do it ourselves? Well, many of us can do this ourselves. Many of us are stuck in a place like this individual who's been on years of Suboxone and methadone. The thoughts are powerful, but sometimes they need a catalyst, like anesthesia. What did I tell this patient? How did I administer the anesthesia to not only prevent an opioid craving, because yeah, we give fentanyl during surgery, we give Dilaudid during surgery, we give all sorts of meperidine, etc. Not only do we prevent, or with this individual's incredible determination and tenacity, were we able to not only prevent a relapse, but we came out actually thanking oxys for the brief period of help that they offered, despite the greater harm, and moved on. So in this specific case, it was a lower extremity surgery. It was in their knee. So I did a nerve block, and I used propofol and ketamine, and I did an opioid-sparing anesthesia. Many people ask me all the time, hey doc, can you do surgery without opioids? All the time. Of course, it depends on where the surgery is, but if it's amenable to doing an opioid-sparing technique like this one with a nerve block and using ketamine, if the patient doesn't have any contraindications or propofol, etc., it can relatively easily be done. Of course, it depends on many factors. This individual told me, doc, I don't want any opioids for my surgery, which, first of all, you got to bring that in. I can't bring that. I can't give that to a patient. I can plant the seed. But when a patient brings that in, that's incredibly powerful. It's a strong predictor of a good outcome at the end. But what happens with that moment of propofol and ketamine? What happens in the brain of an individual who is stuck in such a powerful TBR loop that for years they've been unable to escape despite knowing the dangers of opioids, that helps them literally change perspective, like lift themselves up. You know that poem I always share, the ants, the Rumi poem? The ant is stuck, seeing all these vibrant colors all around him. It's walking inside a Persian carpet. You lift the ant up so it can see the design it's been wandering through for all its life. Then it can recognize that, oh, it's not just random colors, but it's part of a pattern. I have a place in this pattern, or I have a place to be in a different part of the pattern. But it's not all just stochastic, random, everything blowing up around me. It's a sense of purpose, sense of control, sense of guidance. This individual experienced the psychedelic experience with the medications that I gave. I avoided midazolam on purpose in this patient, the medication that wipes memories, because we discussed the risks and benefits, and this individual wanted to do this, remembering whatever experiences they had under anesthesia. And now we fast forward to the story I shared at the beginning. Woke up thanking the oxys, recognizing the control that they had this whole time, letting the oxys in their life. Yes, there's a history of pain. Yes, there's a history of physical pain, emotional pain, etc. And there was a purpose at one point for oxys. But recognizing that they let them in and they can walk them out the door. And this level of control is an antidote to not only anxiety, but also to so many of the cognitive rigidities that we find ourselves in all the time. And it's such an elegantly simple example or simple concept and mechanism, yet it's one that underlies so much of the suffering that my patients have day in, day out, whether in the ketamine infusion clinic or in the operating room, or even in my own personal life with those that I love and share my life with. So, the love and guidance and compassion that I gave this patient with their psychedelic experience, is it too much to ask? Like, we live in this medical system that's just drawn by exorbitant costs that patients can't afford, that are giving subpar results that people are still overweight and dying from opioids with every day. Is it too much to ask that our system give a little bit of compassion and listen to patients? Don't just label them as seekers, but ask, what are you seeking? Why are you unfulfilled? What is it that this addiction is helping you temporarily, at your harm, fill? And how can we uplift you from it, recognizing what you're seeking, and, shocker, provide that? Can we provide what our patients are seeking? That is how you can begin to cure an addiction. It depends on many other factors. But it's what I do with my patients in the operating room or with ketamine. And the risks of ketamine are real, but often are much lower than the risks of methadone for the rest of your life, the risks of an unabated opioid addiction for the rest of your life.